Right. I'm going to get going. Right. Good afternoon, everybody. Good afternoon. It's 3 o'clock here in the United Kingdom, so I'm going to get started. My name is Tonya Burrow, and I have the great pleasure of having Dr. Joyce Elliot on with me, who is a consultant gynecologist and obstetrician. It's a mouthful for me. And also a consultant at the Milton Keynes University Hospital. Obviously, we are live on YouTube, and I'm also going to hit the live button on Facebook as well later. But it's such an honor to have you here, Joyce. How are you?
I'm very well, thank you. It's an honor to be here. Thank you.
Good. Do you want to introduce yourself? Is there anything that I have forgotten or anything that I haven't said while we have a few people logging in?
Well, I think etiquette first of all, thank you for asking me to be part of what you're doing. I think it's an amazing work. Women's health is obviously close to my heart, but if there's anything that you and I can do to help women out there that we've been privileged to be equipped with, I'm very much part of it. So thank you to your family for allowing you, for releasing you to come and do this. And I definitely see that you are shining.
Thank you so much. Right, so I've had quite a lot of, I think what instigated this was, obviously most people know that my major topic and what I deal with is diabetes, and obviously the complexities of diabetes in general practice. And I work with a team of amazing people. Some of them are on here. Hello, Norma. In the course of time, we've had a lot of women who have certain issues and want to find out if there is something in their body, in their genetics, that has actually predisposed them rather to diabetes. And obviously diabetes, yes, I do understand, it's my field, but when it comes to women's health, I take a step back. And obviously I thought to invite you on here. And today we're going to be shedding light to polycystic ovaries. It's a big word, not fully understood by many. So we're hoping that you will be able to obviously let us know.
Yeah.
A lot of questions that people have actually forwarded to me that I'm not sure we'll be able to cover all today. We might have to do a part 2, maybe sometime in the new year. But as much as we can cover today, obviously we would obviously cover it. So my question to you, Joyce, I know I've known you, so I'm trying not to say Dr. Joyce, because I call you by your
Please
first
call
name.
me Joyce. Please
Okay.
call me Joyce.
So my question
It's not that flipping cold. Yeah.
Sorry, if someone can mute yourself as you come in, it would help.
Yes.
Right. So can you please tell us what polycystic ovaries is? It's a very big topic. Can you please tell us what polycystic ovaries is?
I think, first thing I want to say, don't get caught down on terms, okay? There is a bit of a misnomer that polycystic ovary means I have polycystic ovary syndrome, but they're different. Because actually, polycystic, as it says, poly means plenty. You can have plenty of cysts in your ovaries, but actually doesn't mean very much. The question is, do you have polycystic ovary syndrome? Do you have the things that make up the syndrome? And when we talk about syndrome, we're talking about a variety of conditions. And in the context of what we're talking about, you have to have 2 out of the 3, what we call 3 clinical manifestations. So you could have polycystic ovaries and don't have the other. Doesn't mean you have the disease. It just means you have a lot of cysts in your ovaries. Mm-hmm. Whilst you could have the other things and not have cysts in your ovaries, but you can still have the syndrome. Do you see what I mean? So people get very caught down about, oh my goodness, I have a lot of cysts in my ovaries, but actually, do you have the other things? And I guess the next question is, what are the other things that we have to consider? Well, the other things, we have a universal criteria called HOWDEN criteria. You don't have to remember it. That's for me to remember. And HOWDEN criteria basically says that you have to have 2 out of the 3 things, okay? One of them is that you must have very little periods. So I'm talking about less than 4 a year. Or you may have a condition where you have the scan you and they found your ovaries have a lot of cysts on them, and it has to be a certain amount. And or you have symptoms and signs of somebody with, meaning you may look a certain way, you may carry some clinical manifestations, or your blood test might show that you've got these. So you've got to have 2 out of 3 of those for you to have the syndrome.
Okay.
So don't panic. If you've had a scan that says you've got lots of cysts, the next thing you have to ask is, what else do I need to get done? And your doctor will know what to do. Okay? Because I see a lot of women who say, I have cysts in my ovaries. What does that mean? Well, it doesn't mean you have polycystic ovaries. You have to have 2 out of the 3.
Okay, that's interesting to know, because a lot of people hear polycystic ovaries. It's nice to know that there is a difference between polycystic ovaries and polycystic ovary syndrome. That's what you said, right?
Absolutely.
And you have to have 2 out of 3 symptoms to be able to be defined or have that diagnosis of having polycystic ovary syndrome.
Yeah.
Okay. Now, my next question to you is, are people actually born with this polycystic ovary syndrome? Bearing in mind, we've actually separated the 2 now. Are people born with this?
I don't think there's any studies that suggest that people are born with it, but what we do know that certain people are much more predisposed to having this syndrome. And unfortunately, it is, mostly ethnic, people of non-Caucasian origin. That's not to say if you're Caucasian, you're never going to have polycystic ovary syndrome. But actually, what the studies have shown is that there's a higher prevalence in women who are of ethnic origins, particularly South Asian women. But the Black Asian ethnic minority covers it. And therefore, if you're of ethnic origin, you are more likely, there are more prevalence of polycystic ovaries. So you are my sisters, unfortunately.
Okay. All right. That's interesting to know. And one question that was sent in to me that I had to add on to this session was, a lot of mothers fear that when they have female children, like daughters, can it be passed on? So if you're, in quote, obviously at a higher risk or born with this polycystic ovaries, can it now be passed on to your daughters if you have daughters with it?
Mm-hmm. I don't think we have studies to say there's definitely an inheritance factor, but there's clearly a genetic issue, because actually women of ethnic minorities are more likely compared to not to Caucasian. So there has to be some element of geneticism, but you cannot categorically pass on polycystic ovary to your daughter. However, as a mother, okay, I have to be aware that if my daughter has issues with her periods. So my daughter is 17, 18, 19, 20, and she's telling you that she's only getting 1 or 2 periods a year. As a mother, that would naturally raise alarm bells. Because one of the clinical manifestations, remember we talked about 2 out of 3, one of them is getting fewer than 4 periods a year. So that should raise alarm bells. I see polycystic ovaries as this slippery slope thing, we've got to be aware of it being out there. That if you talk about incidence and things, the range goes from 2% of the population to 26% of the population have polycystic ovaries. And if we're not aware of it, we could really be doing ourselves disservice. So going back to your questions, is it inherited? No. Is there genetic predisposition? No, but there is certainly ethnic predisposition. So if you're of certain ethnicity, you're more likely to have it. And therefore you should be aware of what it is. Okay.
That's good. That's good to know. We've had quite a few people join us because obviously we had to start right on time. So I'm going to take you back a step, because some people will be saying, so what are the symptoms? Because you've mentioned irregular periods. And I know that you said if you're having less than 4 periods a year earlier on, can you please just run us through some of the symptoms of polycystic ovary syndrome, mouthful.
Absolutely, absolutely. Absolutely. I say to my patient, a syndrome connotes something that's that's 3 or more. So there are 3 criteria that have been set for polycystic ovaries. And for you to be diagnosed, you have to have 2 out of those 3. So I always use my fingers, excuse me, I'm a mum, so I'm very animated. So the first thing is, if you're having very little periods, so less than 4 periods a year, you should be asking question, what's going on? Okay. If you have been scanned for whatever reasons and they find that your ovaries have lots of cysts and there's a certain number of cysts to come that we have to meet, or your ovaries are of a certain volume, those potentially could mean polycystic ovaries. So those are 2. Or if you have the 3rd criteria, which is so your clinical manifestations, for example, things that you and I perhaps have seen in our friends and family. So there are women who have what we call male pattern hair. So if you're having hair on your chin, hair on the back as a woman, or really bad acne on your face and on your body, that is a clinical manifestation of polycystic ovary syndrome. So
Okay.
you could have the no periods and the cyst, that could be genuine polycystic ovaries, or you could have the cyst and the acne or the male pattern hair. Many of us were women that we've seen who they just seem to have, and they wouldn't tell you, but you can tell that they're shaving.
Yeah, yeah.
Those are clinical signs. Many of us have parents and grandparents who seem to have the odd hair on their face. What's going on there? So that's a clinical manifestation. But remember, you've got to have 2 out of 3 of these to be given the diagnosis of polycystic ovary syndrome.
Okay, thank you for clarifying that. Now, you've clarified the symptoms. My next question to you is, does this polycystic ovary syndrome affect fertility?
Unfortunately, it does. And that's why I use the word it's a slippery slope condition, okay? Because you have many women who may have polycystic ovary syndrome and they have 3, 4, 5 children. And then you may have some women who have polycystic ovary syndrome who are not getting pregnant. And you can imagine, common sense is that if you're not having periods, you're more likely not ovulating, and therefore you're less likely to fall pregnant. Okay, so this is where the fertility link comes in. And what we see often is that women, by the time we see them, is they have been trying for a baby for 1 year or 2 years, and then we find out to say, oh, you're not ovulating, and that's something we can do something about. Okay, so there is a fertility link. So the slippery slope, one of them is not ovulating and infertility, but there are other slippery slopes, and I'm just going to mention them briefly. I'm sure we'll talk about them. The other slippery slope is basically, being pre-diabetic, okay? Because I know this is a topic that we'll touch on later. That condition of where you have what we call impaired glucose means your body is really not able to, your levels are not high enough to be called diabetic, but they're very close. Okay, then there are other things that can lead you down the slippery slope. Heart condition, high blood pressure, all of these are linked with polycystic ovaries. And then you've got cancer. And what specifically is womb cancer. So you can see why it's so important to talk about polycystic ovary syndrome, because it can potentially lead you down in any of those routes if you're not aware of it and if we don't start treating it. Okay.
So my next question was diagnosis, but you've covered that already. So I'm going to jump into the next. A lot of people ask, what is the link? Obviously we know that having polycystic ovary syndrome predisposes you or increases your risk, in simpler terms, to diabetes. How is there a link? What exactly about polycystic ovaries predisposes you to diabetes?
That's a good question. Well, we have to go back to studies, okay? And what the studies have shown is that women who have polycystic ovaries have a condition, one of something called insulin resistance. That means that your body is not responding to the insulin, is not able to use glucose to give energy, okay? Mm-hmm. And that's what is proven. Number two, we also know that polycystic ovaries can make women have what we call impaired glucose tolerance, meaning that you may not have the level of diabetes, but you are very, 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 very close to it. And that is something that can easily be reversible. So those two conditions, that has been proven with many studies that women with polycystic ovaries are more likely to have insulin resistance or impaired glucose tolerance. So this is where the diabetes link comes in. Because actually, if we don't do something about it, it will lead to type 2 diabetes.
Okay. I'm not sure if everyone caught you, but on my end, it kind of froze a little bit.
Oh gosh, okay.
Where you were talking about the link with. So if you don't mind, just in case it wasn't me and your end, how is the link, with polycystic ovaries and diabetes?
Okay, sure. So what the studies have shown, essentially, there are two conditions, the pre-diabetic conditions that polycystic ovaries predisposes you to. Can you hear me very well? I can hear myself echo.
Yes, I can, yeah.
So one of them is a condition where we call you got insulin resistance. So your body, your cells in your body just don't respond well to insulin. They can't use the glucose or the sugar that you have in your body for energy. So you end up with all this sugar in your body that your body should be using. Okay. The second, of course, is that can lead to a condition called impaired glucose tolerance, meaning that your level of glucose in your body, the level of sugar in your body, is almost to the point of diabetes, but it isn't. So we can't fool ourselves to say, oh, actually, I'm not diabetic, but actually, if you've got impaired glucose tolerance, you're almost there. And this is something we can do something about. And clearly, if we don't do something about it, you and I don't do something about it, it will lead to type 2 diabetes, which we want to avoid.
Yeah. Okay. That's good to know. Thank you. Right. Now, how you've talked about ethnicities, and I know you said about the South Asian population, and you also mentioned about the Black African population or the Black American population, or just the Black population in general, those who are more predisposed to having polycystic ovary syndrome. Is that correct?
Yeah, so essentially, if you're of non-Caucasian origin, I'm afraid your risks are there.
Can I ask, is there a particular reason why, that people that are non-Caucasian are more predisposed to polycystic ovaries? Is it something in our diet? Is it something in our genetics? What exactly is linked to our genes and polycystic ovaries?
I think it's the same question you have to ask why are we more likely to have hypertension? Why are we more likely to have diabetes? Why are we more likely to have stroke? And why some other ethnicities are more likely to have lung cancer? Or do you see what I mean? It is that ethnic predisposition, which we can't, in a sense, cut in the middle and say this is a clear-cut answer. We do know that some people, our ethnicity puts us as prone. I don't know the genetic details of it, and I can't lie on mine. I don't know. I'm not a geneticist. What I can say to you that the studies that we follow, that the studies that we advise based on, if you were to split 100 people of mixed ethnicity, and essentially you find that those with Black, Asian ethnic minorities have more predisposed to certain diseases. It goes right back down to one of us going down. Why are we more prone to fibroids? Why are we more prone to hypertension? We have to accept that this is what our genes are like. And until we do something about it, we can't change our color, but we can't change the effect that it has on us, essentially.
Yeah, cool. Right. So a couple of questions were sent in via email to me. And I'm going to mix it in before I go on to the next. Someone asked me two questions. One question was, is there something that they can eat that would help in terms of reducing their polycystic ovary syndrome? Are there foods that they can eat? Is there something in a diet that can actually help them to, be at a better position in terms of, like you said, some women have polycystic ovary syndrome and can have 4, 5, 6 kids. Others are struggling to have children. Is there something that they can eat? Because everyone wants to always go natural first before they try medicine.
Well, I think I have to ask when I see patients, I say to them, there is something that you can do, and there's something that I can do. But polycystic ovaries is one of this condition, I'm afraid, where the actual first line treatment is what you as a patient can do. Okay. And the elephant in the room, and we have to mention the elephant in the room is that polycystic ovaries are much more in women who have a body mass of a certain level. And I'm going to break it down. If you are overweight, if you are obese, you are more likely to end up with polycystic ovaries or syndrome. And this is one modifiable thing we can do about it. So the elephant in the room, unfortunately, comes down to lifestyle. And this is the one thing that medicine hasn't been able to crack. We can crack a lot of stuff. We can treat a lot of things, but we can't change our lifestyles unless we decide to do it ourselves. I, as a doctor, can't do it. You, as a pharmacist, can't do it. We, as patients, have to do it ourselves. So if you ask me, what is the one treatment for polycystic ovaries? The one thing I have to ask yourself, what is your lifestyle like? Do you consider yourself to be of a healthy body mass index? Do you take regular exercise? Have you taken steps to show that you are doing that, you're on your way? And the studies have shown you only have to lose as little as 5% to make a change.
Yeah.
Only 5%. I'm gonna remove the 10. I'm gonna say 5% to make that change, to change your trajectory from being glucose intolerance to normal, to change your trajectory from being pre-diabetic to normal.
Yeah, that's good. I was throwing there before I asked the next question. We had one of the chats with our dietitian, Louise, was amazing. I need to bring her back in, who obviously talked about being pre-diabetic and obviously having diabetes, and she broke down what people should do. It's on the channel, so people can always go back and watch that.
Yeah, I remember.
And it's something that sorry?
I watched it. It's amazing.
Yeah, so I think it's obviously having someone break it down and understand our foods, because being of an African or Asian population, we have foods that actually predispose us. We've got the rice, we've got the yam, we've got the sadza, we've got all these things that we eat that obviously predispose us to having a bigger body mass index than some would do. Now, some people would say, I struggle to lose weight. And I will have people say to me, it's my polycystic ovaries. I do everything that I can. I'm eating right. I'm exercising right, but I cannot do anything about the weight loss. I can only lose maybe 1 kilogram, 2 kilograms because I have polycystic ovaries. Is that true?
Well, actually, no. There is no evidence to say that having polycystic ovaries makes you less likely to lose weight. I'm afraid we have to break that myth. I'm afraid it has to do with mentality. I have yet to see a study that says because you have polycystic ovaries, you cannot lose weight. There is absolutely no link at all. I think what the link should be is education. And what the link should be, what is your goal? Is your goal fertility? Then you work towards it. If your goal is getting a period 4 times a year, you work towards it. Is your goal to stop you being pre-diabetic? You work towards it. But I'm afraid polycystic ovaries doesn't stop one from losing weight. I recognize that losing weight is probably one of the hardest things that we can all do. And I'm a skinny Winnie, so who am I to speak? But if there's effort to show that, if there's evidence to show that you've made effort, there are things out there your doctor can do. You know, the NHS is much more likely now to help people. There are there are drugs that you can use. There are side effects to things that you need to think about. For women who are morbidly obese, BMI more than 40, the NHS is now, you can consider things like bariatric surgery, but it isn't a quick fix, because losing the weight it's about the change in your mind, isn't it? You can lose the weight, but if you don't change what you eat and how you eat, it's going to come back.
Yeah, definitely. Right. So thank you for that. Thank you so much. The next question that was sent to me is, does polycystic ovaries syndrome predispose you to having more fibroids, or the other way around? Because some people think it's got to do with fibroids. I don't know where it's come from, but this question has been asked. having, because a lot of ethnic minority women have seemingly have high fibroid rates. And some of them have said, the doctors have told them that because of the fibroids, they're unable to have babies. So they're linking it in their minds to polycystic ovaries.
Yeah.
Is there a link between fibroids and polycystic ovaries?
There is absolutely no link between fibroids and polycystic ovaries. They're completely two different entities, two different conditions. Yes, they may persist in one person of a certain ethnic minorities, but the two are absolutely not linked. I just feel led that if you are a mum here and you've got a teenager, and I think that's where sometimes we don't recognize, if you've got a teenage girl who is, you look at her and you can see that she's going down a certain body mass index, and I'm going to say she is overweight, and she's putting on more weight. This should be you should have that conversation with her. What are your periods like? What are the implications for, she may not be thinking about having children now, but actually if you have to think, if you continue to put on weight, if you don't make the lifestyle changes, this could have an implication on your pre-diabetic condition. It could have an implication on your fertility. And unfortunately, if you happen to have fibroids on top of it, that's more problems to worry about. But going back to your question, there is absolutely no link between polycystic ovaries and fibroids.
Right.
I'd like to come another day and talk about fibroids, because I think it's worth talking about.
I think that's a topic that a lot of people would want to, because I get a lot of questions. I think once I have people in my room with diabetes, they throw all manner of questions at me, and I'm thinking, this has got nothing to do with diabetes, but obviously we know the people who can answer the questions. So possibly getting you back on sometime next year, hopefully, to cover the topic about fibroids would be great. Now, while we're on this topic, is there a link between fibroids and diabetes?
So there is not a genetic link between fibroids and diabetes. Not at all. Okay. Good. Fibroid in itself is a benign growth that unfortunately we have ethnic predisposition to. And I'm waiting for the day when one of our children will come up with a wonderful treatment for it, or a wonderful drug that will stop us from having fibroids. But there is no link between fibroids and diabetes.
Okay, thank you for that. Now, the next question I want to ask seemingly has the answer yes or no, but obviously I have to ask it because the questions have been sent in. If someone has polycystic ovary syndrome, should they see a fertility doctor if they're trying to conceive, or should they just try to do it on their own?
Okay, good question. So the general answer to any fertility is you got to try and get pregnant. First of all, before you even try, okay, this is what I say to my patients. Before you try, ask yourself very honest questions. Am I healthy to carry a baby? Am I healthy enough to not have complications in pregnancy? Am I healthy enough to look after this child I'm bringing into the world? Those are pre-conceptual questions. Because when, like I said, you could be polycystic ovaries, morbidly obese, and have 4 children, but actually your pregnancy is more likely to be complicated. And you're more likely to have complications because of all those conditions. So the question we have to ask ourselves is, am I of a healthy weight? Is my blood pressure controlled? Have I checked for diabetes? Do I have a strong family history of hypertension, high blood pressure, and diabetes? Have I really optimized my health condition before I try for a baby? So that's the thing. The second thing is that if your answer is yes, I'm healthy, I'm of a healthy weight, yes, I'm not diabetic, yes, my blood pressure is controlled, yes, I'm taking my folic acid, then the answer is go ahead and try. Because actually, you could be amazingly surprised by when you try, you may not need any help from me at all. I'd rather you try and get pregnant than not try at all. So the advice is to try for 6 months to 1 year. If you don't fall pregnant after a year, then go and see your GP.
Okay.
But please try.
Cool.
But before you try,
ask yourself those questions,
because if you're not in a healthy weight, if your blood pressure is not controlled, if you're pre-diabetic, you can fall pregnant, but you subject yourself to so many complications: miscarriage, ectopic pregnancy, diabetes in pregnancy, high blood pressure in pregnancy, premature birth. And then the child is born. The child is more likely to have childhood diabetes. We can change that. You and I can change that. To our audience, you can change that.
Amazing. I think you touched on my next topic there, because you just hit it on the spot. Because my next question rather to you was, does having polycystic, I'm going to just shorten it to PCOS, polycystic ovary syndrome, because it's a mouthful for me. Does PCOS lead or predispose you to gestational diabetes?
Yeah, and really, it's a very simple yes. Okay, it is, if one is known to be polycystic ovaries, we would automatically test you for diabetes in pregnancy anyway. But many of the women who are polycystic ovaries are Black, Asian, ethnic minority. Many of the women are obese, so they're going to be tested anyway. But yes, you are more likely to get gestational diabetes, and the complications from gestational diabetes is something you might want to. It's worth avoiding. Avoid getting diabetes in pregnancy, and it goes back right down to my first question. Before you even get pregnant, ask yourself: am I of a healthy weight? Is my blood pressure controlled? Am I pre-diabetic? So yes, you're more likely to get gestational diabetes with polycystic ovaries. And that in itself comes with this whole conundrum. And I know you've done a session on gestational diabetes with them.
I was going to say.
With Martin. And if you haven't listened to it, do listen to it, because it's amazing. But I'm taking a step before you even get the diabetes, sort things out first.
Yeah, it's funny because people think, oh, it's just gestational diabetes. But in primary care, where we work, if someone has had gestational diabetes, we have to code them here and in the UK. We have to code them as having had gestational diabetes, because once you've had gestational diabetes, you are at a high risk of having diabetes. It may not be now, you may be in your 20s or 30s, but later on down the line. So every year we have to bring you in for a blood test to make sure that you haven't either gone into pre-diabetes or you haven't gone into full-blown diabetes, because then we have to look at all the complications that could possibly happen, from having that. Thank you so much. Now,
and sorry, I want to touch on that if I could. And I think often we as women, we get pregnant, yes, we have diabetes, that gets sorted out, you have your baby, and you forget. We forget, and we think, oh yeah, I've had my baby, that's fine, until next time. But actually, it is that slippery slope. Polycystic ovaries, gestational diabetes, it is that slippery slope that is so easy. Before you know it, the years go by, and before you know it, you're diabetic.
Yeah, cool. Thank you so much. Thank you for that. Now, someone once asked me in my clinic, and I didn't have an answer to it, and I didn't want to make up an answer, because we don't make things up. If we don't know, we say we're research. Now, she had gestational diabetes, and she had polycystic ovary syndrome. But then she's had a hysterectomy. Does that still predispose her to diabetes? If she's had a hysterectomy, obviously for people who don't know, you would explain what a hysterectomy is. I don't want to say anything and obviously get it wrong. If she's had a hysterectomy, does that still predispose her to, because everything hopefully does that predispose her to diabetes?
Yeah, good question. I think the important thing is to differentiate that what hysterectomy is. Hysterectomy is the removal of the womb.
Okay.
Now, polycystic ovaries is a disease that involves your ovaries. So I guess the question to your patient that you saw is, did you have your ovaries removed? And that's when people say hysterectomy, they think, oh, it's just, hysterectomy can be what we call total, with removal of the tubes and the ovaries, or what we call partially total or subtotal, with or without removal of the tubes and ovaries. So I wouldn't be able to answer your friend or your patient unless I ask her, did they remove your tubes and your ovaries? I suspect if she was young, 40s, they may not have removed her ovaries, because your ovaries are really important for you. I suspect if she was in her 60s or 70s, then it is likely that her ovaries were removed. So if her ovaries were not removed, then they are still functioning. Okay. Then in the scenario of polycystic ovaries, well, actually, she doesn't have a womb, so she's not going to get a period. Okay. She is not going to be wanting a child because her ovaries are removed. Her womb has been removed. But if she is still obese, then she may still have conditions. She may still have risk factors that may lead her down the diabetic route. So the question is, if your ovaries are removed, yes, you may still have persisting conditions that may lead you down the diabetic route. If her ovaries are removed, then of course she doesn't have polycystic ovaries, because her ovaries are not there.
Yeah, okay, that makes sense, makes perfect sense. And I hope it helps someone here as well, or someone who's going to watch later. Now, we've gone on and on talked about polycystic PCOS. Like I said, I will shorten it.
Polycystic.
And I think you touched on it. Yeah. Are there medications that can help with polycystic ovaries?
Okay. Remember, it's a syndrome. And so there are different manifestations of the syndrome. So if the problem is fertility, the first line treatment is, I feel like I'm a tape, lifestyle changes. If you're overweight, lose weight. If you're not exercising, exercise. You will be amazed. You will be amazed at how much improvement you can get by just doing these simple things. But if you've done those things and things haven't changed, if you've lost the weight and you're still not getting your periods, and you've lost the weight and you're still not ovulating, and you want to get pregnant, then yes, we can do. There are drugs that we can give. There are risks to giving these drugs. There's risk of what we call hyperstimulation, meaning you can end up with lots more follicles, lots more cysts in the ovaries, predispose you of triplets and quadruplets. And for somebody who doesn't have a child, they'd be like, yeah, I want those, but actually no, those comes with complications as well. So yes, there are drugs. If those drugs don't work, and there is surgery we can do what we call electrocautery. We can basically burst those follicles in the ovary, but there's surgery, and surgery carries risks. So if we can avoid the surgery, just make the changes to lifestyle. So that's for fertility. If you're not desiring fertility and you're not getting periods, we can give drugs to make you have periods, because I just want to touch on that slippery slope. Do you remember I talked about fertility problems, pre-diabetic problems, cancer? So womb cancer, not having periods puts you at risk of what we called hyperplasia. Hyperplasia means that the cells in your womb, they are getting thicker and thicker every time you don't have a period. And as they get thicker, a proportion of those may change to cancer, womb cancer.
Okay.
And this is the message I want to get. So again, to that mother with an adolescent child, if your child is saying, yay, I only have one period a year. No, that is not something to celebrate. because actually those cells that are meant to be shed every month are actually staying in there, and they're getting thicker and thicker and thicker. So if that's a scenario you have, we can give drugs to make you have a period. You only have to have 4 a year. 4 as in a number.
It's quite interesting. Now, can I ask, this is just off, like in my head, is this applicable to, because you talked about, obviously, if you're not having periods, the cells are getting thicker and thicker. Is that still applicable if someone has got, someone's just sent me a question, if someone has got the coil, because they're setting coils that prevent you from having periods. So is that still the same applicable, is that applicable? So if you've got a coil and you're celebrating that you haven't got periods, is that why, or would that still predispose you to having
so the
cancer that everyone's worried about?
Absolutely. So the answer to that is actually, if you've got a hormonal coil, that is one of the treatments that we give for somebody who doesn't have a period, or for somebody who has a thicker cell, shall I say. So if you've got a hormonal coil and you're not having a period, don't worry, because actually the hormonal coil will release something called progesterone, and that thins that cell, the lining of your womb. It makes it nice and thin. So don't worry about that at all. In fact, those are the women who say, yay, I have a hormonal coil, have very little period, rejoice in that one. But if you haven't got a hormonal coil and you're not having periods, or you're not taking any hormones, please see somebody.
Okay. Thank you so much. It's been very insightful. Obviously, women's health is vast. People have sent me questions that are unrelated or related to the topic that we said we will probably bring you back to talk about. But I was obviously passionate about the one that's related to my field, because what we want to do is to reduce the occurrence of prediabetes or diabetes and the complications that arise because of diabetes. We have too many people in our ethnic, groups, or non-ethnic, Caucasian or non-Caucasians, who are having diabetes, and we have to manage them. I have one of my amazing team members, Norma, on here, and we see these day-to-day people having chronic kidney disease, heart attacks, heart failure, and we have to manage all the complexities that come with it. So we are trying to prevent all of this happening and provide education for people. Now, I don't know if anyone's got any questions. If you do, please use the chat box to send the questions, or people have been using my mobile phone, which is not what, to send me questions because they know me. But if you've got any questions that we haven't talked about, please send it to me, and I will ask Dr. Joyce. Otherwise, we will start to wrap up. Thank you, Joyce. It's really been an amazing insight, even for me as a clinician, because obviously we all have our areas of expertise. And I'm glad to know, obviously, I'm going to reiterate the points that you raised earlier on, that there is polycystic ovaries and there is the polycystic ovary syndrome. And there is also the fact that you have to have 2 out of the 3, right? And either you have less than 4 periods a year, you've either had a scan on your ovaries, or you have the clinical symptoms. So you have to have 2 out of the 3. I'm a good student.
You are very good.
Yeah. And you said, obviously, that there are certain ethnicities, like the South Asian or the Black community, that are more prone to having polycystic ovary syndrome, which is PCOS. And obviously, some of the things that we can do is obviously look at our lifestyle. Look at our lifestyle and make the changes to the lifestyle that can actually benefit you. Not just changes because you want to have a baby, but changes because of the complications that arise. I would personally say that diabetes has made a change in my life ever since I've started. I come from a big bone family, and we always use that as an excuse, but having to treat people and see the complications, that's one of the things that puts the fear of God in me, if I am right to say, and helps me to just try and stay as as like controlled as I can possibly be, and obviously make more changes and go down from where I used to be, that you guys know, to where I am now, and hopefully better. So I would encourage everyone, it's not a question of thin versus on the bigger side. It's all a question of what your future health is, because as you approach the late 40s, 50s, and 60s, the complications get more complex. So obviously we need to make the change now. Before I carry on, someone's actually asked a question on here. And the question is, would hormonal imbalance cause PCOS? I think that's the question. Norma, if that's not the question, then obviously correct me.
I think I may have understand where that question is going, is that remember that PCOS is a condition that I just saw her reply, that some women are prone to, and in a sense, you when you talk about hormonal imbalance, there are certain hormones that we can check for that helps us make the diagnosis of PCOS. So one of those hormones is a male hormone called testosterone. If you have a very high level of testosterone, and you have the other conditions, remember, it's not just one. Okay, because actually for some women, they just have the clinical manifestations, or they have no periods on a scan. That's all they have. They still got PCOS. For other women, you may have high levels of male hormones and you have a scan. That's PCOS. So it's not just the one hormone. You've got to look at, do you have the other manifestations of polycystic ovaries? Does that make sense?
Yeah. Norma, is that helped? If it is, send me a message to say it has answered your questions. I haven't seen any other questions. A lot of people are saying thank you. It's mainly sent to my mobile. I don't know why people are using my mobile so I can concentrate. But a lot of people are saying thank you for this conversation. It is very enlightening. And I know a lot of people are not able to make the session because they either have church or they have one activity or the other. So people have said they would catch the replay, and we're live on YouTube. So there are a few people watching it live. It is really insightful. Yeah, what did you want to say?
Yeah, I just felt led to say, I see a lot of women in my clinic who are trying for babies, and they've tried for a little while, and as much as we can do, I can do as much as I can do to help with God's help. But I also I say to women, as much as I can do as much as I can help, but I actually prefer if you're not coming to me.
Yeah.
I prefer if you're not coming to me at all. And you can do that, and you can aim towards that by making certain changes. Okay, and it goes back, I really feel that it goes back to that before you try for a baby.
Yeah.
Make those changes in our lives. Because actually, you may find that you may never need to see someone like me. You may never need to see someone like Tonya. Because you've taken those active steps to look after your health, to be of a healthy weight, to eat well, to exercise. Very, very simple measures. And if you are unfortunate enough, you've done that and things haven't worked out, then there are lots of support out there. The Polycystic Ovary Support Group Society has a support group on the website, so you can go and check their website and see what they can offer women. And there are lots of women in your situations. Talk to your GP, talk to someone like Tony or myself to see what else do I need to do to make those changes to my life.
Yeah. It's I think also what tugs at my heart is obviously coming from an African background and growing up in Africa to a certain level, although I spend more of my life here now than in Africa, you get a lot of people actually being set aside because they don't have periods, or they're made fun of without an understanding of why. And I think hopefully this will bring light to someone. Is not pinpointing to say if you got an extra hair on your chin or if you got really bad acne, but obviously, like Joyce has said, it is something that will make you have that conversation to say, actually, your face is very acne prone. You're actually having more hair. We're not trying to laugh at you. What are your periods like? Should we take you for a scan? And then obviously, if you then have that, And if you're, then we can actually take you to a gynecologist, someone like, Joyce, to say, what can we do about it? Rather than leaving your teenage daughter or your early, someone in their early 20s who is carefree thinking, and then they get married. And in African, Asian cultures, they get bullied or they get put aside because they can't have kids. When we can make a difference, let us make a difference, to people's life. Absolutely. I'm going to end here. Thank you so much, Joyce. I really enjoyed this. I've made notes. Now I can answer my patient to say, I go back into her notes, where her ovaries removed or not removed, and then I can say yes, because her diabetic levels shot up and she was trying to say, no, my I had a hysterectomy, so I shouldn't have diabetes. So I think we have an answer to that. So you've also helped me as well. And thank you to everyone who's joined us, here on Zoom and live on YouTube and Facebook as well. We're honored that you could take time out of your busy Sunday and to obviously spend time with us. Thank you so much. Joyce, do you have any last words?
Hello, and thank you to Tonya. Thank you for this amazing work that you're doing. I think God bless you. We need to hear more of this. We need to have more conversations. I want us to talk about lots more things. But yeah, thank you so much, because this can change somebody's life. So thank you.
Yeah, anytime. Have a good afternoon, everybody. This is
very good, Dr. Elliot. Very good. I'm proud of you, team, UEA team.
Thank you so much.
That has to be Fiona. Great, fantastic job. Yeah, I always love tuning in. So yeah, very informative. Thank you.
Thank you.
Yeah. Bye. Okay, thank you.
Everyone, have a good day. Take care.